and we start eating more and more, we get into trouble. So I think we need to get that sort of message through some experts in the field of diet and weight gain and weight loss. So in the next 4 weeks, we've organized with our the servants in the group, Dr. Ahmed Makari and others. We invited speakers in that particular issue. So we're starting after the Ashaya. First speaker, معنا Dr. Magdy, and then the next 3 speakers would be Dr. Bishay, Rami Bishay, and Dr. Bihari. And the 4th week will Dr. Dua, she's talking about pediatric issues as far as obesity as well. So the theme of the next 4 weeks is diet and obesity, and it's a relevant topic in this fasting as well. So we can use it from a spiritual point of view. And let's pray that the Vespers and the attendance in the Vespers will increase, so people can benefit spiritually. One of the things we were doing at Buena is we confirmed with Sharif and from the IT that they will continue with the YouTube broadcasts for the topics in the next 4 weeks. So whoever watching, hopefully we can reach more people, and hopefully people can see them more in the church. Thank you. Enough church. So we'll continue because everything is ready so we'll continue with you.
الأسبوع اللي فات they invited me to give a talk, and I came and found 3 people attending. I was not frustrated, but I just أحب أقول لكم اللي حصل يعني. إن أنا حضرت كلمة وجيت قلتها في اجتماع جديد كده، والثلاثة اللي كانوا حاضرين، وكان في يوتيوب يعني طلع. وبعدين عرفت إن في أول أسبوع لليوتيوب ده في 400 people visited this YouTube. I'm saying that to the speakers, whether tonight or following weeks, don't worry about people attending here, because الأيام دي ناس كتير قوي بيلاقوا إن من السهل إنهم يتفرجوا على اليوتيوب يعني. كل حاجة متسجلة. الليلة دي مارك مجدي قال لنا حاجة، وهيبقى في فرصة أسئلة. I think يعني speaking English is okay. Please, Mark. I tell you something, we can finish the عشية such that if anyone would like to go, we have absolution, and then we sit down and start. Christus, Isus ben choice.
Skriva si on to kirkinati on obion so kirie brosfamin siom te povo amin.
Irini pasi.
Et pneumati so.
Said Rabbi Sanasikan Khatagul. Blessed in the face of your holy disciple, saying, receive the Holy Spirit, those sins you forgive are forgiven, those you retain shall be retained. Now also our Master, giving grace to those who live and priesthood in your church, to forgive sin upon earth and bind and do everyone to. We bow our heads before your holy glory. Dispense on us your mercy. You've done many sins against you, knowingly and unknowingly, in deeds and in words. You, as a lover of mankind that knows weakness of men, grant absolution to my Father, to everyone, my abject self. بارككم رب وقدسهم محلا امين.
امين. كريا ليسون كريا ليسون كريا ليسون امين. هللويا السبتيك يوكي اجيب نعمتك تاين كريستوسيون اسونيون رامي تروشي بولكوين بوجي وبجويس سوزيفر استابيلري اغوني من اغو شاين تبصوت النوبي سوليمون وناين كريا ليسون Kyrie eplogison emin smoro simetania conievol con behesmo. Amin es shobi. Pazienza,
Please be seated. Mark, please.
Mark, do you have a USB? Yes. معلش
I think it's a lot easier if everyone comes forward. I know no one likes to come right at the front, but for most effectiveness, if everyone comes right to the front, it'll be a lot easier, to be honest. Just in the interest of time, I'll just start. My name's Mark, and I've kind of dedicated most of my career to weight loss. It's really good because it's a big problem. Obesity is obviously growing enormously. And what's amazing about obesity is that it doesn't matter how rich you are or how poor you are, it's something that affects everyone. And that statement's important because Elon Musk, who's the world's richest man, who's an entrepreneur, who's incredibly bright, who's invented Tesla cars, he's invented everything, he's had weight loss surgery. Oprah Winfrey, who's the African-American woman who's incredibly successful, she's had weight loss surgery. So whether you're a billionaire or you're extremely poor, it doesn't matter. This is a condition that will affect everyone. And modern day disease, whether it's a cancer, whether it's infertility, whether it's insulin resistance, these all come from the food that we eat. Now what's important to understand is that what we eat has changed dramatically. So even the way that cows are fed is very differently. So traditionally, you had cows that were eating grass. Now, because the cost of living is so high, you have to have cows and you have to feed them grains. And all the cows are put together, and it's for mass production to generate a huge amount of meat and a huge amount of milk. So all our produce has changed, and the whole world's moving to what we call plant-based. Because when it's plant-based, you can make huge quantities for a large amount of people at a relatively cheap cost. So if you tried to feed your family of 5 a lean piece of steak, which is a good piece of meat, a fresh vegetables for your 2 parents and your 3 children, on average that will cost you about $150 to $200 that night. So if you do that 5 days in a week, that's $1,000 a week just on food. If you stop at KFC or McDonald's, you get a family feed, that's $33. So these companies have capitalized on this and made it a mass production so that food's cheap, it's accessible, and it's very bad quality, okay? But the truth is, that's the reality. That's what we're suffering from at the moment. I was just gonna bring up a couple of things. Surgical options for weight loss. Sorry, so that was my first slide. They're the 2, obviously, billionaires. It's all right. Yeah, so they're the 2 billionaires that I was referring to. This is what is happening at the moment. Ozempic is the most popular drug that you would have heard about. Now, it doesn't matter who you are, I'm sure you've heard of Ozempic. And Ozempic was initially a drug that was made for diabetes. So all the diabetic patients were being put on Ozempic. Then very soon afterwards, they found out that people that were using this drug lost a lot of weight. So what they did was they said, let's stop using it for diabetes, let's use it for weight loss. And so now, if you ask anyone, can they get their hands on Ozempic, the answer is usually no, because it's so popular that it's been sold out globally. So this is the biggest problem at the moment. And I'll show you, if we can just get this slide. Oh, that's good. If you look at, this is the stock market. So the stock market's a measure of wealth. Now, if you were to invest in Eli Lilly, which makes Monjano, or the other company, which is Novo Nordisk, that's the pharmaceutical company that makes Ozempic, they grew by about 400%. So there's a huge demand. Now, any company that grows at that rate is obviously very successful. So the drug works, there's no doubt about it. It's very effective and it's highly sought after. But regardless, if it's not going to work, I wouldn't worry.
2-minute break.
That's right. Regardless, in the US, so where I trained in North America, every patient, before they qualified for surgery, they must go on Ozempic. That's the law. The reason being is, it's mandatory to do a 6-month program. And in the 6 months, they put you on a strict diet, strict exercise, and they put you on Ozempic. If you do well, then you can qualify for surgery. If you don't change your habits, if you make no changes, then the insurance company won't pay for that. In Australia, we're quite lucky at the moment that everyone, if you just turn up to the surgeon and you say, I want weight loss surgery, the government allows that. But they make it very expensive. But at least it's better than the American system where they force you for 6 months to be on the drugs. Now, from my point of view, if the drugs aren't usually available, that's one of the big problems in Australia. The second thing is, because we've got readily access to surgery, a lot of people pick surgery. So we initially had slides because it's very hard to describe these different surgical procedures, but essentially we're going to go from the least aggressive to the most aggressive. And when we talk about the least aggressive, it's usually the least side effects as well. But what you need to understand is that it's like a push bike, a car, an aeroplane, and a jet. You can never expect that a bike is going to do what a jet's going to do. But at the same time, the bicycle is very simple, it's easy to learn, and you've got limitations. So the first thing ever was a gastric balloon. So the gastric balloon, I think it's always easier if I show people. This is literally a human-sized stomach. That's the physical size of a human stomach. So it's quite big. And people don't actually understand how big it can be. But the stomach, it's exactly this shape. And the top of the stomach will begin at a point roughly below your breastbone. So it's about here. And what happens with the stomach is it's like a balloon. It can expand. So if you have something large to eat, it will expand. And if you fast for 6-7 days, it will shrink. So essentially, what we do with the balloon is the following. This balloon was made by 2 Harvard medical students. They were 2 Indian boys, very bright, and they invented this. Very simple. It's a capsule with a string. And what we ask the patients to do is they swallow this with a cup of water, literally. And depending on how tall you are, you need to either swallow 1, 2, or 3 marks. And essentially, when you swallow it, it'll sit. We put around the patient's thing, their ear. It sits in your stomach. And then we do 1 X-ray. Once the X-ray is confirmed you're in the right spot, there's a little infusion through here. So if you see there's a little gadget, we'll blow it up and it will always be this size. So it's quite large, 550 mils. This is a standard size. Then we detach the string. And essentially what this does is, if this is your human-sized stomach, this will take up about 50 to 60% of the room in your stomach. So if I told everyone, let's say we all lived in a 3-bedroom house, and we all had to move into a 1-bedroom house. This is essentially what this is doing. I'm downgrading the size of your stomach. So instead of eating 3 slices of pizza, you can only eat 1 slice of pizza. So essentially, I'm restricting the volume that you can eat. So instead of 3,000 calories, it's 1,000 calories. The advantage is it's simple. You saw it's simple to swallow. It lasts 4 months, and then at the end of the 4 months, this will break down and the patient will pass it through their fecal material. But very simple, it can't be that strong because we're not changing people's anatomy, we're not changing people's hormones. So roughly 10, 12 kilograms maximum. So usually patients that see this is that, let's say it's a young girl who's going to get married in 4 months. She wants to lose 10 kilograms before her wedding. Or someone has an event or something important coming up, they will usually opt for this. The advantage is simple. The disadvantage is it's temporary. But overall, it's a reasonable initiation or a start. And what we're seeing mostly overseas is people use this plus medication, such as Ozempic, which is very popular. After the balloon becomes surgery. And surgery is, I'll just move on, the gastric band. This is very, very popular 10, 15 years ago. You can see that there's the white buckle around the top of the stomach. And what we do is we keep tightening it and tightening it and tightening it. But what we found now is it's a very, very bad way of losing weight. Because every time you eat, you choke. So what we found with time is it was actually a disaster. So lots of patients are actually getting their band removed. So this was a bit of a failure, to be honest. The next operation, this is the most common operation. It's about 80% of patients globally around the world. In Australia, there's about 20 to 30,000 performed every year. This is what we call the sleeve gastrectomy. What we do here is we just get a stapler and we cut through the stomach. So once again, it's always easier with props. So this is a surgical stapler. Real life stapler, very simple. And there's 3 rows of staples. We open, we literally go across the stomach, close, and then fire. And we continue this firing all the way across here, so that it looks a bit like that little banana shape. And you can control the angle, sorry. So the staplers are very smart. So the staplers are very, very well designed. It's medical engineers, very, very safe. And we get the exact angle, the corners, and they keep it very safe and simple. This operation takes about 1 hour, and essentially what you're doing is it's the same as the balloon. We're reducing the stomach by about from 100% down to about 30 to 20%. So once again, we remove volume, but this time we actually remove the portion of the stomach, and so the hormones are changed. The advantage is that we don't actually change your anatomy. We don't replumb, we don't redesign it, we just simply cut and remove. That's why it's very, very popular. But the horror stories come from the staple that fails. And this is a real risk. In about 1% of patients, those staples don't work. And it's a combination. It's a combination of, let's say you've got a bad heart, you've got bad lungs, you're a bad diabetic. This means by definition your tissue is going to be bad. So when you staple through bad tissue, it doesn't heal. And unfortunately that leaks. And these are the horror stories that we hear about where patients are very sick, recurrent hospital admissions, and they get worse and worse. So essentially, if you're a high-risk candidate, this is where the risks come in. But very popular, very effective method. What we also see is about 3 to 5 years, unfortunately, a lot of the patients put the weight back on. And a lot of that's got to do with behavior. So it doesn't matter if your stomach's very small, but if you continue to eat high-calorie, high-sugar drinks, Red Bull, energy drinks, continuous high sugar content, you're still going to put the weight back on. So that's why all the programs, and especially in the US, they're combined. Dietary, psychology, and surgery. So you really need what we call MDT, multi-team. It's a multidisciplinary team, not just one person involved. Next is a bypass. Now bypasses are far more complicated because this is both, we play with your stomach and with your intestine. So this is sometimes where you see the patients who look quite sick or they have major problems. But generally we reserve these operations for more advanced obesity or more significant disease. So if someone's got bad diabetes, they've got a bad heart, they have a bad lung, and they need quite significant intervention, then a bypass, as you can see, it's a lot more complex, but it is involved in the operation. The last one I'm going to speak about is what we call Sadi sleeve. So this is very aggressive. This is a sleeve plus a bypass on top. But this is typically going to be 250, 300, 350 plus. This is very common in the US, where the obesity rates are huge. But in Australia, we do maybe 1 or 2 of these a year, because we don't have that advanced obesity that we see in the US. But essentially, it's the most powerful. We change everything, really. So when we make a decision, there's a couple of key factors. And if anyone's going to consider or they're going to recommend it for someone else, then there's a couple of things you have to really consider. First one is, what is the patient's BMI? So how big is the person? If you want to lose 7 kilos, stay away from surgery. And from a surgeon telling you to stay away, that's a pretty powerful message. If your BMI is 50, so you're 150, 160 kilograms, you can try dieting and exercise, you will never get back to weight, ever. Because it gets to a certain point, when your BMI is above 35, you have less than 5% chance of being successful. And it's because every mechanism in your body, even when you lose weight, it'll make you more hungry to put the weight back on. And this is what we call the set point. The set point is your body sets a point, let's say 120 kilograms. Even when you try to get down to 80, your body will try to bring you back to that 120 set point. So things will change. Your hunger will increase. Your energy levels will decrease. All these things will adapt. So how advanced your obesity is very important in the decision making. The age of the person. If you're a 20-year-old female with no children, it's very different to someone who's 55 post-menopause. The operation itself will change. The decision-making changes. The advice you give to the person. So for example, when we do bariatric surgery, we recommend that no one falls pregnant for at least 12 to 18 months post the surgery, because your vitamins are dropping, your energy is dropping, your calorie intake is dropping. So it's not safe for you to sustain the energy requirements for you and your baby during that period of time. So this is something we also have to consult people about. The gender, so men different to females, obviously. And the second thing is, what work do you do? Because when you lose weight, you will lose muscle and you will lose fat. So if you're a laborer who works a lot of heavy strenuous activity, you need to accept the fact when you lose weight, you will lose muscle mass, you will lose strength. So we get a lot of plumbers or builders who will get quite upset that they've lost a lot of their strength. But that's something that we tell them pretty adamantly about before their operation. Your medical health, this will determine your risk. So if you've got multiple medical problems, you're on multiple medications, then your risk goes up significantly. And that's the risk of something going wrong, unfortunately. And then long-term compliance. So for example, when we have patients who live in the country, they don't have access to hospitals, they've got limited resources, we change the operation. We're not going to do a bypass on those people, because bypass is far more complex and the follow-up is far more intensive. So in those cases, we say a sleeve because it's safer in those contexts. But essentially, there's a wide range of options that are available, and you really tailor it according to each person. And I'm sure everyone's heard of stories about good and bad, unfortunately, but essentially it's a very individualized protocol. And whenever I see someone, I always tell them, make sure you're mentally ready, psychologically ready, and you've got the good support with you. Because the last thing you want is someone to say, oh, why are you doing that? Or why are you taking the easy option? This is not beneficial to anyone. It discourages people, it depresses them about their weight, and essentially it doesn't help anyone. So I tell people, come to me only when you feel that you're ready, when your family feels that you're ready, and you're ready to take on this, because it's not going to be simple. The surgery is not going to be a cure, it's not going to be a magic miracle drug. There's going to be hard effort that needs to come in, and that's where the best results will come from. Thank you.
Thank you, Mark. Anyone wants to ask a question? Dr. Mark?
Mark, about the age. I heard that above 65, you don't do this surgery for anyone. Why? What's that magic about 65?
So there was a big study where they looked at how can we essentially, when you do any operation, you want to increase people's lifespan. So they wanted to show that you could actually increase people's life. So at 65, the damage that's done will usually, it doesn't matter if you operate on them, you won't improve their lifespan. But you can improve their quality of life. So that traditional rule of, the cutoff at 65 has actually been moved up to 71. And that's been in recent times, that's in the last 2 or 3 years. But essentially, when you tell people, because unfortunately in bariatric surgery there's a very high litigation rate. So I can't say to someone, you're above 65, I'm going to increase your lifespan, but I can say, we can improve your quality of life from 65 onwards. But essentially that rule has been cut out, essentially. The other important cutoff is in children. That's very controversial. So in children, there's a big cutoff. So there's 2 schools of thought. Some people say you should never stunt a child's growth. At 13, 14, let them grow. Then the other school of thought is that children are going to get bullied. They're going to get picked on at school. They're going to have major psychological disorders. And so by the time they get to 18 and they qualify for surgery, a lot of psychological damage has been done. So this is where it becomes a big debate between the pediatricians. And for some reason, the pediatricians are very fixed on one belief or the other. It's very hard to find someone neutral. So when I don't want to operate on someone, I know exactly who to speak to. And when I do want to operate on someone, I know exactly who to speak to as well. Because they'll declare exactly which way they want to go. But the truth is, in my personal experience, like the youngest I've operated on is a 13-year-old. And I personally believe that the benefit to him was much better because he wouldn't go to school. He stopped going to school and he was depressed and his education suffered. But as soon as we managed to lose he didn't go to school for 3 months after the operation. But as soon as he went back to school, he changed schools so people wouldn't know, and he went back like a normal pupil. So that was a clear, to me, that's obviously well. But if someone's a little bit chubby, then I think it's a bit too aggressive to operate on a 13, 14-year-old, to be honest.
Do the surgeries, can they affect your set point and reduce it?
That's the theory of bariatric surgery. So if your set point was at 120, when we operate on people, then it causes a chemical imbalance. And then they reset to a new set point. And that's the whole rationale behind it. The truth is, it's a variation. But we find that people lose 30, 40 kilos, depending on the type of operation. But things like the band or the balloon won't reset your set point.
Is one surgery better for set point?
Yeah. The more aggressive you are with your surgery, the better it is for effectiveness, but the higher your risk profile. So if we did sadi sleeve on everyone, we would make people very sick from excessive weight loss. So picking the right, essentially what we think will happen in the future is that we'll all have a blood test. And then the blood test will say, for you, a sleeve is the best. For you, a bypass is the best. For me, a band is the best. So we'll be able to tell, based on chemical and our biology, what will be the most suitable operation for that person. But at present, we still don't know. We kind of, most of us do a sleeve first, plus or minus a bypass.
What are all the benefits of weight loss? We know that, of course, we'll have better figure, but what are other benefits we get?
Yeah, I'll show you an interesting slide. This is a very interesting slide. And what you'll see here is how much percentage of weight loss you need to get the health benefit. So for example, when you lose 10% of your body weight, you will have a very significant improvement in your diabetes. That's the same for things like your cholesterol and your blood pressure. Once you start getting into 15, 20%, then things change. But essentially, this is why we always say to people, if you can just lose 10% of your body weight, you'll have a very significant improvement in your health. And so this is why the drugs have become so popular. Because the drugs, they're nowhere near as powerful as surgery, but they will get you 10% body weight loss without the risks of surgery. So what I find is most people come to me and they say, I want the drugs first. And if I can't fix my cholesterol and I can't fix my diabetes and I can't fix everything else, then I'll have surgery. And to be honest, I think that's very reasonable. The only downside to that is that you need to tell people, if you're going to start the medication, it's likely that you're going to be on it for the rest of your life. Because the minute you stop the medication, your weight will come back on. But if you gave people the option, once a week injection versus major surgery, 9 out of 10 times people will pick the drugs. And I'll give you a classic example. When the heart surgeons used to do a lot of bypass, okay, then the stents came out. If you tell any patient now, would you prefer a bypass or stents? 9 out of 10 will pick a stent. Even if they have 10 stents, they'll still pick over a bypass. Because bypass surgery is major surgery. And it will knock you about. And it will take you 6 months to recover. So the stent, you go in the morning, you come out the next day, you'll be back to normal like nothing happened. So it's the same thing in weight loss. You can take a medication once a week. You might feel a little bit of nausea. You might feel a little bit upset. But relative to what we do to people, is very different. But we also need to be reasonable. Like when people come and see me and they're 60, 70 kilos overweight, the drugs it's just not powerful enough at present. But like everything, I think the drugs will get better and better. And it's only a matter of time before really, I think most people will be on medical therapy and surgery will only be for the super, super, super obese that are 80, 90 kilograms overweight. And to be honest, I think that's good for everyone. If you can minimize complications, give people good quality of life, and they take a medication once a week. I mean, most people above the age of 65 now take at least 1 tablet a day. So taking an extra injection once a week might be quite beneficial. It's not good for my job prospects in the future, but still, I think overall it's still fine. Yes.
Mark, what?
Is there a higher risk for morbidly obese patient to have the operation?
Yeah, the problem with the more obese you are, then usually the more comorbidities you have. So they've got a higher degree of hypertension. They've got a higher degree of bad cholesterol. They've got a higher degree of diabetes. So you can have diabetes and you're just on a tablet, or you can have diabetes and you're on the highest dose of insulin, high dose. So the damage from long-term diabetes is horrible to your tissue. So you know that their eyes get damaged, their kidneys are damaged, their tissue gets damaged, and more importantly is that their healing potential is significantly altered. So when you operate on a super obese person, technically it's not easy, and even their healing potential is significantly altered. So that's why we typically talk about 2-stage procedure. So we would do an initial sleeve just to make more room, decrease their fat, lose 20, 30 kilos, then we'll do a more aggressive surgery on them later. But they definitely have higher risks. So we break it up into less than BMI 35, BMI 35 to 50, and 50 plus. 50 plus is very high risk.
Mark, as far as the balloon for this type of patients you described, which could be suitable for them, the balloon has sort of long-term success. I know some people just use the 5s. And the other thing, the symptoms, it looks like a big thing. They have continued to have these 4 months, a lot of symptoms, pressure, anything like that? What's your...
The biggest downfall of the balloon is that it's temporary, and the results are temporary. So we find that most people, they'll lose 10, 15 kilos for a period of 4 months. They might keep it up for 6, 7 months, but it's very hard for them at 12 to 18 months to keep that weight off. The sensation...
Is that because of the habits? Like, it hasn't changed the habits?
Yeah, generally it's habits, or they've got a clear indication at the time. So almost, I would say about 40 to 50% will be young females. They'll see me and they've got something coming up. They have their sister's wedding, or they've got their own wedding, or they're going overseas, or they want to meet someone. So they've got this clear drive. Once that drive or that event has happened, then the motivation drops. So when the motivation drops, the habits come back. So, they used to have sugary tea in the morning, bubble tea. They'll stop that, because the other thing that you'll find is that when people have a device, or when they're being watched or monitored, all of a sudden their behavior gets 100 times better. So to a certain degree, I feel a lot of this is psychological as well. When you have a balloon, all of a sudden you start to behave better. You'll start to exercise. You've never exercised ever in your life, but when the balloon goes in, you'll start. So it's a big motivator for people. And so the other thing is that they're not cheap, and there's no rebate on it.
That's why I asked. Yeah.
Yeah.
So, yeah.
So when people start or they invest money, then that, for me, I see the biggest driver of people is finances. The minute you tell people I'm going to incentivize you with money, all of a sudden their motivation goes up 1,000,000 times. Whereas when you tell people it's going to be charity, you can see there's very little motivation. So when people pay for a balloon and they know it's a temporary period of time and there's a fixed date, they tend to do quite well. So you'll be shocked at the results that you can get with a balloon. But long term, no, the results are not great. But because patients, it's like they want to achieve something. I want to get to this weight by this date. They're not upset 18 months later when they put the weight on, because when they wanted it most, they got it. So that's why the satisfaction is pretty high with a balloon. And in terms of the sensation, yes, you feel it. So when people, they say I run, I jog, I can feel a bouncing sensation. We tell people no contact sports, so we don't want to hit anything. But it's not the most comfortable. Like when you feel this, like I encourage people to feel it. It's 550, it's quite heavy.
Yeah, it's just how would you put that in?
So, and if you put it against your own stomach, you'll be shocked at how...
What's the content like?
Inside it is saline. Because if that ruptures for whatever reason, it's just going to be, it's going to be... And we usually mix it with a blue dye. So the blue dye, once it pops, if you see blue, so if a patient calls us up and says, I coughed blue, or I start to spit blue, or I saw blue in my urine, we get worried straight away that that's popped. Yeah.
Thank you very much for
my
this excellent presentation, and I'm sure there is a lot of people they missed out, and I'm sure that because of you and the attendance today, I'm sure that more people will be coming next week. That's really, really excellent. My question to you is, we've been doing the gastric sleeve for the last 15 years, roughly.
Yes.
And we discovered, as you said, after a few years, a lot of people, they gain weight again. Not all of them, people who are able to achieve, control and have behavioral change, they may maintain their weight, but a lot of people, they regain their weight. One of the things I want to ask, what happened to the stomach? Does it stretch again? And if it stretches again, is it any chance to, I know that they prefer after gastric sleeve, they're doing bypass, but is there any reason not to do or redo gastric sleeve surgery?
Yeah, so we order a test, it's called a fizz CT, F-I-Z-Z. And what happens is they drink a fizzy drink on purpose. And what it will do is it will blow up their stomach. And it will give us a volume. We'll see how big their stomach is. So normal sleeve is about 150 to 200 mils. The fizz CT, you can see up to 350, 400 mils. So they've definitely stretched it. The next question is, we used to re-sleeve a lot of people. But your risk from a sleeve, re-sleeve. So the first sleeve, we quote you as 1% leak rate. When you re-sleeve someone, that risk goes up to 10%. So all of a sudden you go from 1 in 100 risk to 1 in 10. So that's a very significant risk. Whereas if I convert a sleeve to a bypass, my leak rate is 2.5%. So it becomes a numbers game. So if I'm going to tell someone you've got a 2.5% chance of a leak versus a 10% chance of a leak, everyone's going to pick 2.5. Unless you have a clear reason not to have a bypass, then we'll re-sleeve. But we'll tell them very carefully that your risk is significantly higher if I do it. And there's a famous quote. We had a big conference one time, and the man from the conference said something very interesting. He said to me, Einstein has a famous saying. Einstein's saying is, if you do the same thing over and over again and you expect a different outcome, this is called insanity. Yeah? So if you did a sleeve and you regain the weight, why would you re-sleeve this person? because you're going to get the same outcome. They're going to be back to you, and you're not going to re-sleeve them again. Yeah. So his rationale was, do something different. The first one didn't work, so change your algorithm.
Mark, with the leak as a complication, is as bad as with upper GI as lower GI?
The problem
is it as fatal as?
Yeah. The problem with our leaks is because in the stomach you've got bile and you've got acid, all of it together, the leaks are catastrophic. So these are, unfortunately, so at St. George Hospital, it's a real international centre. So there's some pretty big names, like very world-renowned surgeons there. So we see some of the worst complications, unfortunately. And so, but it gets shipped from all over the country. So it's a real hub for bariatrics. And what you'll see is you'll see some young people for 1 year in hospital because it's a leak and they take back to theatre and wash out and then we put a stent in and this. So these things happen. So when people come in and they just say, oh, look, I'm just going to have surgery, it's not as light as people think. It's not common, we're talking 1%, but if you're that 1%, then your life is miserable. So in particular, with stomach, it's a nasty organ when things don't go well. It's a bit like the pancreas. Like, God forbid anyone has pancreatic cancer, because pancreatic cancer is very different to a different type of cancer. Stomach leak is very different to one of the other leaks, unfortunately.
One last question about the medical Ozempic and Manjaro. We had some bad publicity about it and paralytic alias and so forth. Are you worried about it, or it's just something bad press, or what do you think?
No, there's definitely, it's like everything. There's going to be a subgroup of people that don't do well with Ozempic, and they're going to get bad. So essentially, what Dr. Nader was saying was that when you take Ozempic, it paralyzes the stomach. And so food gets stuck, and you can eat food from 3-4 days ago, and it will remain in your stomach. So we see this a lot, and I'm sure you see it as well in your surgery, that when the anaesthetist comes to do the surgery, they say, oh, there's food in the stomach, which is a high risk. So we do see this. We see gastroparesis. But generally, I haven't seen any major problems, to be honest. But from the anaesthetic point of view, they do get worried about their paralytic alias.
They usually ask, the anaesthetist will ask the patient not to take it for at least a week or so before,
yeah.
because of that complication.
Our protocols are the same. So any patient going to have surgery, then we tell them, 1 week prior, withhold the Ozempic. Emergency surgery, like we all have, you don't have an option, but they've got their rapid sequence induction or whatever it is just to get through. But to be honest, I mean, a lot of the stuff that I've seen has been abuse or misuse of the drug. So it's like anything. People are impulsive. They want quick results. So they'll double the dose or they'll triple the dose. Then you see complications. There's no doubt about it. But this is user error. This is not the drug. But people like to blame the drug, of course.
Is the staples are metal staples?
Yeah, they're titanium, and there's 3 rows. We say they're tri-staple technology. And the rationale being is if one fails, you've got 2 more backup. So, yeah, when you go to the labs, it's really amazing. The engineers, there's a big divide between the engineers and the surgeons. So they're very academic, and this is how the staple works. Perfectly aligned, blah, blah, blah. And the surgeons, it's like 2 different worlds. It's very amazing when you interact with them, because they're very fixed on their technique and they've perfected the instrument, but they don't care what we think. Like when we say we don't like the handle, they say we don't care. Yeah. So they want to make the best product and just make us adapt to their best product. They don't make the product for us, essentially.
Is any change regarding the government attitude towards managing public patient or having this type of surgery accessible to public patient?
It's a very sensitive topic, because I went to the government officials for this, and the man said to me very clearly, he was the health minister, he said to me, if we open the gates, we will be flooded, and the health system will be bankrupt. That's what he said. He said, the only surgery we'll be doing will be weight loss surgery. So the minute you open the gates, it's over. So it's better to keep them shut. So they have zero intention of doing this. Yes, of course.
Set the point on different layers. So you've done it with the surgery, but is there a way that you send people away to probably therapists and just try that instead of just Ozempic?
There's a lot of different groups out there. So there's behavioural therapy. There's even shockwave, where people run electrical currents to try to shock people. None of these groups have been effective, though. There's what we call CBT, cognitive behavioural therapy. They put them in rooms together, and then they try to elicit what's bad food and what's good food, and they try to really manipulate. I personally, I'm a believer in every type of medicine, whether it's contemporary medicine, whether it's alternative medicines. If it works, then try it. But yet, in my practice at least, and from the literature that we haven't been able to find an adaptive method to change people's set point, unfortunately. But that would be the key to the success, to be honest. We know from pregnant women, so one of the biggest studies that we found is that if a woman has a baby and she cannot get back to her pre-baby weight within 12 months, it is very unlikely that she'll ever get back to that weight. So there's obviously a protected time period where you can put on weight, but you've got the reset button, and there's a window of reset. Once you breach that window, then no, it's like it steps onto that layer and it will stay there. But there's fixed points, and for women, it's babies and menopause. And for men, it's roughly what they equivalent to menopause. So as men reach about 40 and their testosterone drops, that's also a set point. So that's why you'll find, they'll say the middle-aged man with a belly, okay? Because that's the same concept of it, that their hormonal profiles change, that they've also put on the weight. Thank you. Thank you very much, everyone. Thank you.
Thank you very much, Mark, for this excellent talk. And we'd like to see more of you again. It's very, very good. Thank you very much. Okay, God bless you. Micah is Allah. We just we invite him to say a couple of words from a diet point of view, and after that we'll conclude. Next week we'll have Dr. Rami Bishai, I think, talking about obesity from a medical point of view and endocrinology. So that will be exactly the same time next week. So thanks, Mike.
Thank you, Dr. Mark. I think that was a really good presentation. A lot of patients come and ask me, should I take the surgery, shouldn't I? And I always say, let's just start with diet and go from there. The end objective, the goal, is to lose the weight. That losing the weight is what will improve your health overall. So if you beat around the bush and you just keep the weight on for 10, 20, 30 years, it's not in your benefit. The benefit is to lose the weight. And we try all approaches. We start with diet, then pharmaceutical, and then surgery, as Dr. Mark said. But like Dr. Mark said, the behavioural has to change. Your attitude towards food has to change. The way you eat has to change. I've seen people that have come to the practice that have had the weight loss surgery and they continue to have thick shakes, chocolate milkshakes, V's, Red Bulls. The surgery becomes redundant in that case. So the question is, how can we change that approach? Like Dr. Mark said, you need to have some sort of psychological intervention. Why? A lot of the time people are doing this because this is how they feel better. They have a bad day, they go towards the chocolate, they go towards alcohol, whatever it may be. So that needs to be managed from that perspective. The diet also needs to be educated on, because there's certain things that we can eat that are more nutritious and lower in calories, and there's certain things that we can eat that are higher in calories and less nutritious. Certainly the way society has moved forward is that the food is a lot more processed. It's a lot more calorie dense. In 50 grams of food, there's a lot more calories now than it was 100 years ago. And so in many aspects, what we need to do is go back to basics and have less refined foods. The less refined it is, the better. So we look at whole grains, we look at vegetables, we look at fruits, and we try to avoid things that are highly processed. Another thing that people often don't take into consideration is alcohol. Alcohol has a lot of calories in it, 7 calories per gram, and so it's another killer. Just having that glass of wine regularly it's not good for your weight. And of course, just having what I always call musiba food is, the donuts, the chocolate, all that nice food that we enjoy that makes us feel good. It's a musiba, so we just try to keep that minimal. Thank you.
But not the kahk.
Not the kahk, of course.
Thank you.
تفضلوا نصلي. بسم الله والابن والروح القدس الأحد آمين. نشكر فضلك يا رب وتدبيرك الحسن لينا. علمنا يا رب ان احنا نقضي ايام غربتنا بسلام وبقداسه. ادي صحه لشعبك يا رب. بارك على عملهم. وكل ما تمتد اليه قديمه يا رب يكون من نجاح والبركه. اقبلنا ليك يا رب متشفعين بالعدل وما مؤس. ندعوك بشكر ابانا الذي في السماوات. محبة الله الآب ونعمة الابن الوحيد شركة وموهبة وعطية الروح القدس تكون مع جميعكم. امضوا بسلام. سلام الرب يكون مع جميعكم آمين. عندي أمل أن الإخوة المسؤولين عن الاجتماع ده الأسبوع الجاي يقدموا لنا حاجة نشربها بعد الاجتماع. عندنا جوسر حاجات حلوة الأسبوع الجاي إن شاء الله. الأسبوع ده معلش. امضوا بسلام.